So hi, my name's Alice. I'm one of the F2s at St Mary's, currently on surgical liaison. And my colleague Harry also helped me write this talk. He's also an F2 with a keen interest in haematology, but he's just been pulled away. So I'll try and do his slides justice. So today we're going to talk about, well, the name is When to Worry About an Anemia, and I'm going to discuss a case that I saw on nights, that there was a query if they had quite a worrying condition that includes anemia, and then we're going to talk a little bit about what that condition is. So is it going to let me click on? So the case involves a 51-year-old gentleman who was a referral from the Western Eye Hospital. He initially presented to the Western Eye with a 4-day history of floaters and worsening vision, and that had got significantly worse in the last day. Apart from that, he was completely well. He didn't report any other symptoms. So he was seen in Western Eye, and they examined his eye. And they sent him over to us, and on their kind of referral form, they said that they saw retinal hemorrhages and they were queering Roth spots. And because of that, they needed to rule out infective endocarditis. So because of that, he ended up being referred to the acute medical take at St Mary's, and that's how I encountered him. So when he presented, so just a bit about his background first, sorry, he's usually fit and well, no underlying medical conditions, fully independent gentleman with no significant alcohol or drug history. And apart from this issue with his vision, he had no other symptoms, no other history was given. On examination, his obs were stable, he was afebrile, he was musing a 0. It wasn't actually myself who clerked him in, it was the day team, and they noted this. They said a possible new pansystolic murmur. The gentleman didn't know if it had ever been noted before. He wasn't from London, he was visiting friends in Southampton, and he didn't often attend his GP. So we said that it was new based on that. He also showed us some dark macules that were on his hands. They weren't particularly in keeping with Janeway lesions, but because of the possible Roth spots, the new murmur, and now these marks on his hands, we did need to rule out infective endocarditis. So that was our working diagnosis. And the feeling was, because he was so well, it was likely subacute.
So let's check. So from his point of view, he's a well guy with a bit of visual problems and suddenly called in for all this panic.
Yeah.
Right? Yeah,
that's essentially it. I think he was quite taken by surprise.
I bet he was.
Yeah, and there didn't seem to be too much of a focus on his vision by the time he got to us. Yes. We were more worried about everything else. So what was handed over to me was to chase his bloods, and the day team themselves said, I'm not expecting much, just check his inflammatory markers, and you know, if they're not particularly raised, then he may be able to be discharged. So that's what I did, and it was a busy night, and I got round to checking them around about 11:30. And this is what I saw on his full blood count: a HB of 48, platelets of 74, and also if you see his MCV, he's macrocytic. Initially, I actually didn't think it was a true reading, so I repeated a gas, and that was true. I think on the gas his HB was 47, and if you look at the remainder of his full blood count and his biochem, his renal function was completely normal. There was nothing really to mention about his inflammatory markers. His fibrinogen was ever so slightly low, but apart from that, there was nothing else really to point us in a direction.
Can I ask the audience to look at that full blood count and make any other comments?
Yeah, so
anybody?
Neutropenic?
Yeah.
It's an interesting, yeah. And the platelets are even red. So there are a number of interesting things. Okay. So just bear that in mind, everyone, and carry on.
So I suppose my question is anyone has any thoughts about what might be going on, or what else they might want to send or add on?
Blood film?
Yeah, blood film. Yeah. Anything else?
Reticulocytes?
Yeah. So that's essentially what we did. We added on a blood film, and this is what it showed. And I know someone mentioned it, and that was the reason we put it on the opening slide. It showed us schistocytes, and it also said that the reduced platelet count was genuine, because sometimes the platelets can clump together. So at that point, we were wondering, was he hemolyzing? So this is what we got from our hemolysis screen that we added on. His reticulocytes weren't particularly raised, but his LDH was very high, but his total bilirubin was normal, and his conjugated bilirubin as well. So again, that didn't really give us any more of an answer to why his HB was 48. So what we did then was I needed to repeat the bloods because I needed a group and screen. And we repeated the bloods, and it showed us a HB of 47. His platelets dropped slightly. And if you see his neutrophils are coming down, I mean, it's a very moderate decrease, but they are trending down, and he is becoming lymphopenic now. His fibrinogen is also dropping, and his D-dimer is going up, which worried us slightly. And we actually repeated the bloods again further into the night because we had to send more samples. And that showed us that he had actually become neutropenic. And again, his fibrinogen was dropping and his D-dimer was going up. And so, I mean, it's the middle of the night and we have this essentially pancytopenic patient and we don't have a cause. And the blood film is showing us schistocytes, which is quite worrying. So we called hematology. And they raised the concern of possible TTP because he was thrombocytopenic, he was anemic, there were schistocytes on the blood film. And they very kindly calculated the plasmic score, which is a scoring system for TTP. Now, fortunately, he scored a 4, which is low. So for anyone who's not familiar with the scoring system, 0 to 4 is low risk. I think 5 to 7 or 8 is moderate, and then upwards is high. And they advised that we send a whole host of tests, which I've detailed here. So G6PD, lupus anticoagulant, and an Adams TS13 sample, which I'm going to talk to you a little bit about later on, but I don't know if anyone's ever sent one of these. And if you ever have to in the future, it involves couriering a sample over to UCL. And they actually called us, the TTP consultant called us the next morning to discuss the case. You also have to email. And sorry, I've clicked on a bit too far. And this is what we got back from these results. Essentially, it didn't give us any more answers. His complement was slightly low, but apart from that, the rest of them were negative. The Adams TS13, the range on our system is 60 to 146. So although his is slightly low, it wasn't, alarmingly low. So that essentially did rule out TTP, which was quite reassuring. But that came back, I think it came back a couple of days later. So in the middle of the night, we weren't aware of that. But what we did notice further into the night was that his hematinics had come back, and he was significantly deficient in B12. And when we asked him, he hadn't got any malabsorption type symptoms. His bowels were working regularly. He had a varied diet. He didn't abuse alcohol. And hematology, we spoke to them several times throughout the night because of his clotting and how much we should transfuse him. And their impression was that his pancytopenia was caused by this severe B12 deficiency. And he got this bone marrow failure, which I've actually never seen before. And I wasn't super aware that this could happen. I'm not sure if anyone else has seen this. And we did, treat him with a severe regime, as a severe deficiency. And I guess before we go on to the next section of the talk, where we're going to talk about TTP, the main learning points that I got from this case was, first of all, do the really obvious things first, like the hematinics, although they take a while to come back. And the second thing, maybe more for the juniors like myself, the F1s, the F2s, maybe the IMTs, is if you're seeing a thrombocytopenia and a severe anemia, to get a blood film sent off, because that's really important, because if it's TTP, prompt recognition improves your survival rates. So I'm just going to stop there before I go on to the next stage, where I'm going to talk a little bit about TTP and see, does anyone have any questions, or if there was anything different they would have done. And also if anyone had any ideas about why he might be so B12 deficient.
Any thoughts from anybody?
Would the B12 deficiency explain the schistocytes on the blood film?
Well, that's what I wasn't sure about. I don't think that it would, but hematology is feeling well, or what they wrote afterwards was that the pancytopenia could all be put down to the B12 deficiency, and actually not much more was said about the blood film.
Because Andrew's written in the chat, he's written pernicious anemia, which is which gives you anemia, but I was unaware that you got a low white count like that.
Yeah.
And you know that there's still lifelong B12. The other thing is being vegan is another cause.
So his diet was actually normal. He wasn't vegan. I also wasn't aware that actually B12 deficiency can cause pancytopenia.
And Neil has put metformin can lower B12. That's an important thing for us all to know, just generally. Yeah,
he wasn't taking any regular meds. We sent off a celiac screen on this patient, and we checked his intrinsic factor antibodies, and they were all negative. And actually, he was followed up in the hematology clinic, and then he went back to Southampton, and everything kind of normalized. But we never really got to the reason why he was so deficient. And actually, I haven't managed to come up with a reason. And I was just wondering if anyone else had any more ideas.
Now you can't see the chat because you can if you want to, but I'll tell you what it says. There's a few thoughts. Someone's written nitrous oxide, which is a thought.
Okay, I didn't actually ask him about that.
Okay, but the other thing is a direct antiglobulin test. Used to be called the Coombs test. Was that done?
I think we did send a DAT test, but I can't actually remember the result. I'm sorry, I didn't include that in my talk.
Because if you've got an autoimmune hemolytic anemia, then that's a very clear positive. So that would be quite interesting to see if you've got hemolytic.
So I don't have access to CERN. I'm actually at home today, but yeah, that's worth.
Okay, that would be interesting. So that's a thought. What did you say he got B12? Was that injections of B12?
Yeah, so I think we gave him IM injections, and I think we put him on a 3 times a week regime with the GP to then step it down and to link him in with his hematology department in Southampton.
Because if it is pernicious anemia, then you load them up with 1 milligram of B12. I mean, 300 a week is a bit much, but that's the protocol, and they end up on 1 milligram every month, I think. Yes, and Doris has pointed out that hemolysis and the Coombs test would not lead to macrocytosis and pancytopenia. Yeah, I think that's true. You're right, of course, Doris. That's it doesn't quite fit, but it would be nice to get all those results to see what they found.
Yeah.
But are we now saying that the patient went home on B12 and everything else recovered, including the neutrophils?
Yeah. Everything recovered really quickly. It was quite an odd picture because nothing really matched up.
Okay, incredible. Any thoughts, maybe? So we actually don't know the diagnosis. Is that right?
Well, we know that it was the B12 that caused pancytopenia, but we don't know we don't know the root cause of the B12 deficiency.
So it could be pernicious anemia if it's autoimmune.
His intrinsic factor antibodies were negative, so we screened him for that and celiac.
Okay, so we really don't know.
Yeah, he remains a mystery, and now he's gone off burner. Yeah.
And has he had a bone marrow?
No.
Really? Because I thought they'd run around with their toolkit and drill a hole in his bone.
Yeah, he didn't have bone marrow. He was followed up and repeat bloods and everything just recovered. He was still slightly, I think his when he was seen in hematology, his HB was 115 when I looked him up most recently, but now he's gone, he's not local to us.
That's a shame. Okay, and Alex Novar's written, what happened to his eyes?
Yeah, that was the other thing. No mention of his eyes in his discharge. I mean, when I went off nights.
Okay, and his echo?
Nothing.
Okay.
I think we asked the GP to do an echo because of a new murmur.
Okay.
So he remains a bit of a mystery.
Yeah, I mean, the murmur might be a flow murmur because, of course, if he's that anemic, you would need quite a high cardiac output. So it might not even be a real murmur. But anyway, it's okay.
So for people who are interested, then the next part of the talk, we're going to talk about TTP.
Which is nothing to do with the patient necessarily.
No, that was our main concern, and that's what we were ruling out throughout the night. Actually, he turned out to be less exciting than we thought, but we thought we tied in with some TTP teaching because it's something that you read about and then often never see.
Yeah, thank you.
Just to refresh people's minds. So it was first discovered in 1924 when a 16-year-old had fever, weakness, focal neurology, and thrombocytopenia. She then subsequently died, and she had an autopsy, and that showed widespread thromboid, and it was coined a Mostrovitz syndrome. And then in 1947, it was renamed as TTP, which we know it today. And in 1966, you got this pentad of fever, thrombocytopenia, hemolytic anemia, renal injury, and neurological features. And I suppose the reason that, well, it made me excited in the middle of the night was it's got an annual incidence of 1 case per million. So actually a lot of us may never see it. 90% of the time it's seen in adults, and it's twice as common in females as it is in males. So it's all based on this Adams TS13, which is an enzyme for regulating von Willebrand factors. So you get shear forces on the vascular endothelium, and then von Willebrand factor unravels and exposes its A1 domain. And then that interacts with the platelets, and your platelets aggregate and you get hemostasis. And then how it works is the Adams TS13 is a negative regulator. So it interacts with von Willebrand factor and it causes proteolysis. And when you're deficient, you get these large von Willebrand factor multimers and unregulated platelet adhesion. So the interesting thing is it was only fully identified in 2001. So that's really very recent. It's only 21 years ago. And its only known function is in terms of regulating von Willebrand factor. And for it to be, it makes up part of the diagnostic criteria for TTP, and that's why we sent an urgent sample, because if less than 10%, then that is diagnostic of TTP. So the causes are either congenital or acquired. So you can have mutations in Adams TS13, but they're very rare. And then others are acquired. So you get these autoantibodies, which either provoke the clearance or it gets rid of Adams TS, and then you get this unregulated platelet adhesion. And things that cause it are things like post-infection, so urinary, GI. So if you think back to our case, he actually had no preceding illness. He wasn't pregnant, he was male. Tumours, SLE, HIV. So HIV was negative on this gentleman. The evidence in drugs is pretty mixed. The thought is that these drugs are indicated in TMA. The only one that there seems to be a clear indication, and I'm willing to be corrected on that, in TTP is ticlodipine. So if you see a patient on that and then they're anemic and thrombocytopenic, maybe be a bit worried. And then this is how you diagnose it. So they'll have a MAHA, they'll have neurological symptoms, they'll have fever, thrombocytopenia, and renal dysfunction. And actually, one of the things that I only learned doing this talk is that the renal dysfunction is often an isolated proteinuria or hematuria. Often it's not so much an AKI, and that might move you away from the diagnosis of TTP. So if you see anyone with that pentad, again, think TTP. So things that you will find is a thrombocytopenia and a MAHA, but it's the blood film really that will well point you in the diagnosis. And you will see these schistocytes, which were on the opening slide. They can be helmet-like cells. They're irregular. They're tightly contracted. And then other things you might see is organ infarction, and they can get things like neurological symptoms as well. So aphasia, diplopia, headache, and confusion. And they can get cardiac ischemia, mesenteric ischemia from the kind of platelet adhesion, dysregulated platelet adhesion, and renal dysfunction, which actually our gentleman, his renal function was completely normal. And then other findings will things be in keeping with hemolysis, like a raised LDH, a raised bilirubin, and an absent hepatoglobulin. And then something else that's worth thinking about is hemolytic uremic syndrome, it's biologically indistinguishable from TTP. It's more other features surrounding it that will make you think about it. So first, it's the age. So in kids, you're more likely to get HUS, whereas in adults, you're more likely to get TTP. And then the symptomology. So things surrounding it, you know, HUS is associated with E. coli. So you're going to think, have they been on a farm, undercooked meat? Whereas TTP, often they have kind of these non-specific preceding symptoms or non-specific neurological symptoms like a headache or some kind of increasing confusion. And then the final thing is the Adams TS13 level, which is linked to TTP. It's important to recognize both of these conditions because prompt diagnosis then leads to early management, and they do have a high mortality if they're not, you know, correctly managed and identified early. So plasma exchange is one of the key ways we manage it. You can use steroids, and you can also use rituximab, which is a monoclonal antibody for, I think, CD20 if it's refractory. And other managements that are managed are NAC, bortezomib, and recombinant Adams TS as well. So that's just a very brief overview. I know it's mentioned a lot in exams. The key distinguisher for people doing exams is neurological symptoms, think TTP, whereas otherwise maybe go down the HUS if it's a farm or undercooked meat. But it's just to refresh people's memory in case they ever see any of those things.
Okay, that's really good. That's really clear. There's a question about IV immunoglobulins, which might also be used for TTP, for thrombotic purpura.
Oh goodness, I don't know. These were the managements I've come across. I think it's plasma exchange that's used in the first instance. Yes. I don't know if anyone knows differently to that.
Yeah, I think there was a study some time ago, and sometimes they would exchange with IVIG.
Okay.
But yes.
Yeah.
It's a question. There we go. Zoe said it is used. I think I've seen it used. Yeah, it's used. Yeah.
I don't know if anyone has any questions or if anyone has actually seen it.
You've got a few acronyms there. NAC being N-acetylcysteine, I'm guessing.
Yeah.
Yeah. And
yes,
HUS,
yes.
Just to make sure everyone knows HUS.
Oh, sorry, hemolytic uremic syndrome. Yes. Yeah, sorry.
Which is a pediatrics kind of thing. Okay.
Yeah, more seen in peds.
Yeah, I've seen a few interesting cases throughout my career. I've certainly seen TTP postpartum. Cyclosporin was thought to be one thing. I've also seen familial cases of hemolytic uremic syndrome. I mean, I think the most important thing, the most important message is this is a rare condition. It is very rare, but you have to diagnose it very early. There is a risk of stroke and catastrophic complications if it's not recognized in time. This man, if he had it, would have had a very mild case and a very early case, the patient. But I think the main thing is that you have to think about it, and the diagnostics, I think, is relatively straightforward for looking at a blood film and looking at these enzymes, but you're going to have the clinical scenario developing in front of your eyes before you actually get the test results back, and it's important to seek very early advice from hematology around the management, which is quite difficult to organize. So yes, if you think about it, the diagnostics, it is something that's very rare. Lots of people will not have seen it, but it is something that is a genuine, very an emergency. People can have strokes and get very disabled with it if it's not treated in time. Yes.
And I think that was our worry. I know our gentleman didn't have it, but that was why we discussed it with hematology quite a few times, because he did have one or two of the features, and I guess we didn't want to miss it, although he was very well. So it probably then got pushed further down our list of diagnoses.